Yeah, I mean, this is in the category of the silent things that happen to women. And that bone loss, a third of the women die from the consequences of bone loss because you need those hormones, particularly estrogen and progesterone, to have strong, healthy bones. And when you lose that, there's a gradual loss of bones. And then as an expert in treating old people taught us in medical school, a gerontologist, he said, here's what's happening to old people. They're losing their muscles and they can't stand with stability, and they fall on their osteoporotic bones, and they die from the hip fracture.
Welcome to the Radical Health Rebel podcast. I'm your host, Lee Brandon. This work started for me several decades ago when I started to see the impact I could make on people, helping them to identify the root cause of their health problems that no doctor could figure out, including serious back, knee, shoulder and neck injuries, acne and eczema issues, severe gut health problems, even helping couples get pregnant after several IVF treatments had failed. And it really moves me to be able to help people in this way. And that is why I do what I do and why we have this show. In this week's episode of the Radical Health Rebel podcast, entitled How to Thrive in Menopause, Dr. David Rosensweet and I got to discuss a very important topic that affects millions of women across the world and can ultimately lead to a miserable middle and late stage of life, often requiring a cocktail of pharmaceuticals and 24-hour care at great expense. Hormones are a subject that I've had a very special interest in since the early 1990s, so Dr. Rosensweet and I got deep into the subject of menopause and, more importantly, how to thrive during and after menopause. Dr. Rosensweet shares his 50-plus years of experience working in this field, and this episode is one that no woman or man above or even approaching 40 years of age should miss. David Rosensweet, welcome to the Radical Health Rebel podcast. Thanks for coming on the show.
Thank you, Leigh Brandon. Good to meet you. Good to be with you.
Yeah, you too. So, David, to kick things off, could you share with the audience an overview of your career to date and how and why you became interested in helping women to thrive in menopause?
Yes, and I knew that I wanted to be a doctor when I was 14. And when I reached medical school, I really felt like I had arrived at my church, my synagogue. It was a really sacred experience. And then near the end of my training in medical school, I started being interested in other things. I wanted to learn about nutrition. I wanted to learn about how do you help people get healthy. And I mentored with some of the old-fashioned docs who they all seemed to have a trick. And really, it was the birth of holistic medicine. It didn't have a name back then. And I just kept acquiring tools. And, in the early 1990s, I was a functional medicine, holistic medicine doctor. That's what I did. And then along came one of my patients early in the morning, Deborah. She opened the door of my consultation room without an appointment, walked up to my desk and said, I am desperate. I am going crazy, which was a shocker because I knew her to be brilliant. She had retired in her 40s. And I serendipitously, all of our careers are guided magically, but serendipitously, I had just had a communication with a world expert on progesterone. And I gave her some progesterone, and 3 weeks later, I got a letter from her saying, oh my God, I can't believe this stuff. I'm totally myself again, and I was going crazy. And that was very impressive. And then she referred women to me, and before I knew it, I had a practice that was really robust in treating women in menopause. And it really suited me greatly because I love biochemistry, I love hormones. And I decided to specialize in it because there was more and more to learn. And then I started treating men. And so here we are. I am primarily training and mentoring physicians and nurse practitioners on how to treat women in menopause. And then along the way, some partners came along because our mission is huge. We feel like this earth desperately needs input of empowered women, and women fall off the cliff midlife. And at a time when they're at the peak of their experience and their knowledge, and we think feminine energy must come back to save this planet, and at every level, family, business, politics. So my group is big, and we want to get millions and millions of women. And then, of course, the women want their men on the hormones once they experience it. And then I'm a man, I'm on hormones. I love them. I'm so grateful for them. So that's what we do.
Awesome. So just to take you back, so you say you trained in functional medicine, is that right?
Well, there was no official training back in 1968 when I started out. But there were these docs who were experimenting with B12, with nutrition. There were PhDs. There were people interested in nutrition. There was a whole group of health conscious folks that were very famous at the time, and I learned from them. I learned a lot of stuff. So you keep picking. I had a very curious appetite, and loved it when I linked up with someone who knew some good stuff. And how do you help people heal? Yeah. How do you stay healthy? And my body of knowledge just grew and grew and grew. And then I've had the opportunity to be trained and mentored by some of the pioneers in functional medicine long before it was called functional medicine. So that's been great.
So originally you trained as a medical doctor?
Absolutely.
And how long had you been practicing as a medical doctor kind of before you found your path, so to speak?
Well, I started right in medical school and as a senior looking for other stuff. And so when I hit the ground running in a private practice in Santa Fe, New Mexico, I was doing home births. I was already looking at nutrition. I was very interested in organic back then. I'd grown up basically with organic. And so they didn't have a name back then. It just had a lot of information and tools. Yeah, so right out of the gate. And that's what this was late 1960s, early 70s. There was a burgeoning interest amongst people to how can we get healthy? Can we do this life better than our preceding generations have? And so there was a natural fit there.
Yeah, it sounds like you were decades ahead of your time, really.
Or right on time.
Yeah, look at it that
way. The earth needed to change, and it was really that desire for change and desire for personal and growth was exploding in myself and in a lot of people in a whole new generation. Yeah. And so there we were doing it together.
Yeah. Awesome. So before we go any further, could you, might have some younger people perhaps listening to this show, explain what menopause is and what the typical symptoms are?
Sure. The hormones are the most potent biochemicals in our body, nothing stronger. And our output of hormones, of all of them, including testicular and ovarian hormones, peaks around the age of 20, plus or minus a couple of years, in men and women. And then they gradually decline. And that decline is has significant consequences because we need these things. And then in women midlife, there's an abrupt secondary decline beyond just the basic decline. There's abrupt decline where the ovaries stop producing. And that's extremely consequential because these ovarian hormones, I'll just focus on women for a minute, they're so important. And without them, ultimately over the long run, and people don't get to know this unless you're a medical doctor really, or a very observant layperson, is at the end of life in the United States in the 90s, it's about assisted living facilities and nursing homes for a lot of folks. And how they get there is primarily, not exclusively, but 80 to 90% of the people who wind up in nursing homes and assisted living facilities do so because of the hormone loss. It's a big deal. And men too. You know, most men start experiencing that deterioration in the 40s or 50s. And then along comes erectile dysfunction and they really start to experience it. And, but the deeper things are what the more consequential things, the loss of muscle. Mm. That's what leads to canes, walkers, wheelchairs, adult diapers. So these hormones are so powerful, but it creeps up on you in many cases. It doesn't creep up in women. Yeah. Over 80% of the women, when the ovaries stop, they can't sleep. They have mood issues, anxiety, depression. They got these disruptive hot flashes that wake them up in the middle of the night. Loss of libido. They get vaginal issues. It's a big deal. And I always think those women are the most fortunate because these symptoms are so life disruptive that they're reaching out for help. And, you know, best case, they find someone who knows what they're doing. They get those hormones replenished because there's never been a better time in history to replenish these hormones. And they're back in the saddle and very grateful for it. Yeah. And the same for men. You know, all you got to do is talk to a man who's lost his erection and felt hopeless about it. And Viagra is great, but it isn't enough. Yeah. And gets his erection back, and he's going, this is good stuff. I'll be on it for the rest of my life. Oh, yeah.
And osteoporosis is another symptom, isn't it, of women post-menopause?
Yeah. I mean, this is in the category of the silent things that happen to women. And that bone loss, you know, a third of the women die from the consequences of bone loss because you need those hormones, particularly estrogen and progesterone, to have strong, healthy bones. And when you lose that, there's a gradual loss of bones. And then as an expert in treating old people taught us in medical school, a gerontologist, he said, here's what's happening to old people. They're losing their muscles and they can't stand with stability and they fall. And they fall on their osteoporotic bones, and they die from the hip fracture. You want to do something for old people? Take care of their bones and their muscles. Yeah. So great place to start, Leigh. That's
yeah. So I mean, as well as, you know, perhaps augmenting with hormones, exercise would be an important aspect as well, wouldn't it? To put the stress through the system.
Yes, it really is. But, you know, it just won't. I mean, we all know how important exercise is. So we all know the consequence of not doing exercise. It's really not okay. Yeah. However, without the testosterone, you lose the muscles eventually. And I'm talking about women and men in their 70s, 80s, 90s. Without the testosterone, and women got to realize that they have more testosterone in their body than they have their most potent estrogen, estradiol. This testosterone is critical for women, and being treated with testosterone is critical. So, and of course, exercise. I don't mean to diminish the power of exercise, but you can't keep it. 90% of the people cannot keep their muscles unless they also have that testosterone replenished.
It's interesting. I was looking at a video the other day of Robert F. Kennedy Jr., and I think he's 67 years old, I believe, and he is in absolutely amazing shape. And I looked at his body and I thought, there's no way he's not using some kind of hormone treatment at that age to look that good.
Yeah, I mean, the wealthy, many segments of the wealthy, not all of the wealthy, they've known about this for a long time. The Hollywood movie stars, they find their way to doctors who have the extra added attraction of extending their lives and strengthening their lives. And I've seen that in Kennedy too. I've seen those videos and I went, look at those arm muscles. Yeah. This man's got to be on hormones.
Yeah, for sure. So let's take the average person or average woman, let's say. She's going through menopause. She's got, you know, some of the symptoms that you suggested. She goes to your run-of-the-mill doctor or endocrinologist. What would be the standard approach in the medical system?
Great question. You're talking about the elephant in the room here. Unlike any other branch of medicine that I've been a part of, the whole field of hormone treatment had a deleterious event that has shaped women and men's access and concern about hormones. A false report occurred in 2002. In the United States, 40% of women in menopause were on hormones prior to 2002, and they did so much better than the women who weren't on hormones. And then this large study was falsely reported. It was falsely reported. It said there was increased risk. But when you read the study, that's not what was true. But the press got a hold of it, and there's, God knows how misogynistic energy can really occur. But it said to women and healthcare providers that hormones will cause breast cancer, heart attack, and stroke. It wasn't in the study. In the study, the estrogen hormone, Premarin, horse urine-derived estrogens, had a 21% reduced risk for breast cancer than women who were not treated with hormones. It was Prempro, the other hormone, that had a statistically insignificant increased risk. And they said that right in the study, but people didn't pay attention to that. They just saw 1.26 relative risk. And it scared women all over the world. In the United States, and it scared healthcare providers, and this really addresses your question. So the whole field where all kinds of specializations were occurring, neurology, internal medicine, thoracic surgery, obstetrics and gynecology, there was no specialization occurring in hormones outside of the endocrinologists who were treating diabetes primarily. The whole field got stunted because everyone got afraid that they would be causing increased risk. So for the most part in the United States anyway, if a woman goes to traditionally trained doctors, the doctors who care about their patients are going to say that, no, I can't treat you, we'd be putting you at risk. Now, this information has been retracted. The original study committee in the 2000 and late teens reported in the same journal that after 18 years of follow-up, there was no increased risk, breast cancer, heart attack, and stroke. But hardly any physicians have seen this. They still are working off the false information that was given in that original report. So your question was, what happens if you go to your GP or someone? It takes the most open-minded, knowledgeable ones to know the facts. And here's the facts. If I may take 30 seconds to tell you what the facts are. Here's the science. We're all at risk for all kinds of diagnoses, thousands of them. Some of them are not okay. Most of them are not okay. We're all at risk for cancers, men and women. We're at risk for, as a man, I have an increased relative risk for getting prostate cancer, and there's reasons for that. And women have an increased relative risk for getting breast cancer. That wasn't always the case, not when I was in medical school. There was no increased relative risk for breast cancer. It existed, but it didn't have any increased relative risk. But given that we're all at risk, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than those women who do not receive hormone treatment. Men who are treated with testosterone are at less risk for prostate cancer than men who have low testosterone and are not treated. And even women who've had breast cancer and have had that breast cancer properly treated with whatever it takes, surgery, radiation, chemo, whatever it takes, had that breast cancer properly treated, they happen to have an increased relative risk for getting a recurrence of that breast cancer than a woman has in getting breast cancer. But women who've had breast cancer properly treated are at less risk for that recurrence if they're treated with hormones than if they are not treated. That's the science.
Yeah, it's interesting. Yeah, when you mentioned prostate cancer, and the kind of general belief in the medical community is that prostate cancer is linked to high testosterone levels, and yet men get prostate cancer when their testosterone's at its lowest.
That's right. And there's an expert who's written about this. He's a urologist in the United States at Harvard. His name is Abraham Morgentaler. And he's written a book and he lectures all over the country training doctors. And I recommend you get Dr. Morgentaler's book if you're a man and you're concerned, because the science is different. The science is there's less risk, just like you just said. Like,
yeah. There's a good book also called The Prostate Hoax. That's quite a good book as well. I can't remember who the author is, but it's a good book. So you've mentioned, if postmenopausal women use hormones, it lowers their risk of a number of diseases. Is there any diseases that it increases risk when you use hormones?
It's not the hormones. It's never the hormones. That's something that people really want to pause and get. Hormones don't cause illness. Diminished hormones cause problems. All kinds of problems. I mean, these hormones are related to the amount of energy your body's able to produce. And energy is the coin of the realm. You don't get to have a functioning immune system without sufficient energy. It's well known during COVID that young women, because of their estrogen, had less severe problems with COVID than young men, just from the estrogen alone, because their immune systems function better. So there's so many moving parts to how we get ill. There's thousands of events that are adverse taking place throughout the course of our life. Issues of nutrition, issues of toxic exposure, issues of too little exercise or too much. And issues of the elephant in the room is really a dysfunctional, exaggerated response to the stresses of life. These are the four major causes of illness. One could throw in another one caused not explainable by ordinary science or means. These events, these breaches of healthful practice that take place over the course of the lifetime, these do cause illness. In other words, you got to eat well, breathe well, not get toxic exposure, exercise, and develop information, tools, and skills and support to heal the emotions and consciousness and your perception and your choice and your ability to love. These are imperative, because without that, illness results.
Completely agree. I first met Amelia at a health club where I was hosting an event offering back screenings to the members. The first thing I noticed about Amelia was a dullness in her eyes, which I later realized was due to extreme pain, and I noticed that she was unable to turn her head and had to turn her whole body if she wanted to look in a different direction. Amelia informed me that she had a history of repeated shoulder and neck pain for the last 2 years and was diagnosed with spinal stenosis at C4-5, C5-6, and C6-7, and a stenosis is a blockage which in Amelia's case was in the spinal canal of her neck, irritating her spinal cord. She had extreme tenderness over her neck and trapezius muscles on both sides, and she suffered from severe neck pain continuously. Amelia informed me that she'd been advised that spinal surgery was the only option, but the surgery came with great risks, including potential paralysis, and no guarantee of success, which made Amelia fearful of the surgery. In addition to this, Amelia suffered from continuous exhaustion, painful intestinal gas and bloating, even though she felt she was following a healthy diet. After a thorough evaluation, I designed Amelia a corrective exercise, nutrition, and lifestyle plan, plus I referred her to a NUCA chiropractor for specific adjustments to her neck. After following the plan religiously, Amelia is much stronger and much more flexible than she's ever been before, and no longer suffers from repeated neck pain and has full range of motion in her neck. Amelia also reported that her energy was maximized and that she no longer suffers from the gripping stomach pains that had dominated her life for a very long time. If you're suffering like Amelia was and you'd like to find out more about getting to the root cause of your pain, go to www.bodycheck.co.uk, that's bodychek.co.uk, to request your consultation. So obviously when we're talking about hormone therapies, there's two different types, right? You've got the patented kind of pharmaceutical, let's call it less natural version, and then you've got the bioidentical hormones. Can you explain what the differences are between the two?
Yeah, there's historical differences. I mean, human beings have known about hormones and have been treated with hormones for 1,000 years. The Chinese, what they were doing is they were gathering the women of the urine of the women, young healthy women, and in another batch they were gathering the urine of young healthy men. They were drying it out and giving them to the aristocracy, and it kept the aristocracy youthful because there's hormones in the urine. And then in the 1940s, the pharmaceutical industry figured out that there was a great need for hormones, and they wanted a really robust source, so they chose a large animal, horses, and they chose them when they're pregnant mares, and they catheterized them and collected the urine and dried out that. And that's Premarin, pregnant mare urine. And that became the most popular and profitable drug of all times. And you know what? The women who were on Premarin and Prempro did much better than their counterparts. And yet, things progress. I mean, in the early 1980s, independently, a compounding pharmacist in Dallas and a holistic medical doctor, Dr. Jonathan Wright in Washington, thought, we think that there is molecularly pure hormones available. Why don't we get those? And there was, because the pharmaceutical industry had learned how to extract from soybeans, primarily, and yams, but primarily soybeans, the precursors. And when they took those precursors and they biochemically worked with them in the lab, they could produce molecules that were 100% identical to what came out of the ovary or the testicles. That's what bioidentical means, or body identical means. Same molecule. So Dr. Wright and his pharmacist and Jim Hernser, the pharmacist outside of Dallas, they put these up in skin creams and gels. And that was the birth of administering compounded bioidentical hormones to women and men. And I'm a big tent kind of guy. I say whatever a woman prefers, whatever providers prefer, they all have value and they all reduce risk. But my goodness, when I started doing this, I saw those bioidenticals and I said, I want that stuff. And that's what I started treating women with. And you can attain a level of precision and individualization that is imperative for best medicine only if a physician or nurse practitioner, for example, can write an infinite amount of prescriptions, because every woman and every man is different from the others. That's not a problem to someone who knows what they're doing. So the number of different estrogen prescriptions that we can write are totally customized to the individual woman, and only a compounding pharmacist can make those up. So I much prefer the individualization, and so do patients. They much prefer the precision. And then we went a step further. My team and I, many years ago, led by my son actually, we saw that the topical hormones were being put up in strong solvents, so we developed an organic oils base way to dispense these. And pharmacists do that because we think it's very important what you put on your skin. And women are putting these hormones on twice a day. And they're putting on a quart a year if they're using creams and gels. So we developed an organic oils way to do that. And these are certified organic base. So that's sort of the broad spectrum. All these hormones, when administered intelligently, in which you give enough and not too much, they're all good. So we're Big Tent. We say however you can get them.
Gotcha. Yeah, I've actually read Dr. Wright's books on menopause and andropause. Yeah, really good book.
Great.
So we've got two different types. We've got the synthetic types and we've got the bioidentical. For me personally, I'm guessing you're the same. If something's natural, I would rather use something that's natural rather than something that's synthetic. Is there any downsides that you feel towards the synthetic types?
Well, there might be a downside to the combination of an artificial progestin being added to the horse urine-derived estrogen. And these are the same molecules, are very similar to what's in birth control pills. Progestins, they're called. They're not progesterone. Progesterone is a natural female hormone. There are downsides of the progestins. Yeah. Absolutely. And yet, we're resilient. For most people, the birth control is important. We just don't throw out everything just because, it's all risk benefit. And in general, most women are resilient enough to withstand this artificial molecule and even thrive on it. Do well, have contraception. But, we always strive for, what's the safest, healthiest, and most effective? I don't want to prescribe an artificial change in the progesterone molecule. I want to give women the same molecule that they had in their bodies. So there is some downsides to the progestins. There's downsides to too much and too little of whatever you've got going on there. We don't know if there's downsides to the Premarin. We don't know this, that women who are on Premarin are less risk for breast cancer, heart attack, and stroke, even though 50% of the estrogens that are in horse urine are not found in the female body. We definitely, science has shown us that there's less risk involved there. And so, we all get to choose, right? At least in this day and age. There's a lot of pressure from the pharmaceutical industry. They lost so much market share when the compounded bioidenticals came along in the United States. There's a whole challenge going on in the United States. And I'd like to say that in Britain, you all have had such amazing groundswell of support. And there's a medical doctor there that is at the vanguard of this. And now the British healthcare gives away free hormones to women in menopause. Why did they do that? Because they saw that if you prevent the deteriorations that get women into nursing homes, the benefit to society and the benefit to the cost of healthcare is astronomical, because the most expensive healthcare costs are derived from the end of life, when there's hospitalizations in nursing home facilities. Yeah. So Great Britain and a few Scandinavian countries have figured this out, and they're offering free hormone replacement, hormone treatment to women in menopause. I salute you all. You're way ahead of us here. It's brilliant.
Yeah, I mean, obviously there's a lot of politics that comes into medical care as well, isn't there? So,
yes, there is. And there's a lot of corporate captures, and they think that they should own the right to everybody's money.
Yeah.
But that's a whole other topic, Leigh. I won't go there.
So you've alluded to the fact that everyone's different. So everyone needs their own individual treatment. So I'm guessing you must do some kind of testing prior to deciding which treatment each person should get.
Well, with women, it's a mistake to test women. I mean, when are they showing up to doctors' offices? When they're symptomatic. And that can be as early as in the perimenopause. That means their ovaries are starting to get erratic. They might be having hot flashes, a sign of low estrogen. They may be waking up in the middle of the night with racing mind, another sign of low estrogen. But once the ovaries start declining, the body makes a last-ditch attempt to address that decline, and the pituitary gland puts out these stimulating hormones periodically, and instead of these nice, smooth menstrual curves of the output of the ovarian hormones, you get this erratic thing. Higher peaks of hormones coming out of the ovary and lower low ends than ever before. But over the course of the month, it adds up to low. But if you test a woman on the wrong day who's having hot flashes, you could test her on one of these peak days and you get high estrogens at a time when this woman desperately needs estrogen. How did I learn this? By making the mistake of testing women in the perimenopause. There's no need to. We test 100% of the women we treat, but we wait until they say, and it's usually at the 3-month, 4-month mark, oh my God, I feel like myself again. We do 24-hour urine hormone testing, which is the gold standard, on every single woman when she's arrived at the proper dosages in her individualized situation. You could test a woman in menopause who's no longer having periods. And I did that in the beginning. And what did I learn? That she was low in hormones. She didn't have enough hormones to menstruate, for example, super low in hormones. Well, she had the privilege of paying $300 to get that information from me. And I got to see what I learned from her because her period stopped. So there's no sense in testing a woman's hormones when her periods have stopped. So for women, perimenopause, don't test them. You'll get erroneous results. And for menopause, don't bother. You're just going to give them an extra $300 expense or more if you do blood testing. But test 100% of the women you're treating when you've helped them determine their optimal dose and they've oscillated in and they've got it. Men's a little different. The world of treating men in andropause, it's grown up on blood testing. And it's not easy to bring in 24-hour urine hormone testing, which again would be the gold standard, to men. So we divide our male population into two groups. Those who we just don't think they're going to do the 24-hour urine hormone testing, and then we're going to work with blood testing. So men, we test 100% of the men by blood prior to that first consultation and prescription. And then we track men once they've arrived at clinical satisfaction. We repeat that blood testing. There's several indicators in men that make it a little more practical to do blood testing. For example, you have a man who's lost his erection, lost his drive, lost his libido. He's low in testosterone. We get his initial tests of a lot of different things. Then we put him on a treatment program and he feels better and better, gets his erection back, his drive back, his libido back. He says, wow. And that occurs at the 1 to 3 month mark, depending on the age of the man, primarily. Then we repeat his blood test. And you could have a man who's feeling really good, but if he's on too much testosterone, he's going to get too much estrogen because estrogen's made out of testosterone. He's going to get breast development. And men don't like that. And if you give him too much testosterone, you're going to raise one of the male hormones called DHT, dihydrotestosterone, and the man's going to lose his hair. And if you give a man too much testosterone, he's going to raise his sex hormone binding globulin. That's problematic. If you get into those kind of situations, you may have to give a man a medication to lower his sex hormone binding globulin. It's a slippery slope. So with men, there's these specific blood tests that we can monitor that we can't in women. So we're doing a two-pronged approach to men. We're satisfied and happy to treat men who only want the blood testing, and we're running a certain level of our patients who are willing to spend the extra $300 for the 24-hour urine hormone test just to see how important it is. Because in women's medicine, because the women are on the hormones, you need the 24-hour urine collection. Like, when do you draw the blood on a woman that you're treating? Prior to her taking her morning hormones? Well, they're going to be lowest then. Or an hour after she took her hormones, or 2 hours after her hormones. Same problem exists with men. When did you draw their blood? Well, the tradition is you draw it in the morning, whereas other physicians say you draw it at 3 hours. But every man is different. So there's studies that show that there's a lack of steady state when you're treating with hormones. So that's why we're very interested in the 24-hour urine hormone test. We've done plenty of 24-hour urine hormone tests in men, but we're wanting to see, can we honor and respect that we're going to get more men on the hormones, and we can monitor them by blood testing, because there's these alarms that go off. A man can feel great, as many men on testosterone injections do. And then I test them, and their estrogen's rising way too high that I know what's going to happen. They're going to get breast development that they don't want. They're also going to get shrinking of their testicles. They don't want that. And so we've got these safety catches with men that makes blood testing, we've got an extra added protection there. And I just looked at a blood test come in this morning. The man feels great. His testosterone is 700. That number may not be meaningful to some of your audience, but his DHT was up. You expect to see an elevated DHT when the testosterone levels are too high, like 1200, 1300. Well, his was up. So he's feeling great, and I get to tell him, well, we got to do something about the excessive DHT. We don't want that.
Yeah, is DHT related to prostate cancer as well?
Well, it's a curious thing. Hormones don't cause cancer, and DHT is a very important hormone for us males. And there are plenty of causes of cancer.
Mm-hmm. Yeah. And,
I listed the 5 major causes of cancer, and there are thousands of adverse events that where the cancer and the illness really comes from. That's where we want to look, to the causes. Now, will DHT cause a prostate cancer to grow faster? Or cause a prostate itself to enlarge, which is enough of a problem in itself? Yeah, it can do that. So no worries when you're working with someone who understands the moving parts. We just don't let those things go there. Or if they've gone there, we just correct them. We're trying to copy nature.
Yeah.
We don't allow a man to produce high levels of DHT. We pick up on it really early. This man's 3 weeks into his treatment that I saw this morning. We picked that up on it in 3 weeks. Okay. So we take measures to lower that DHT.
Yeah. So going back to the women, so you don't test them, and you'd explain very clearly why.
Well, I'm sorry. We do a series of blood tests on women. We just don't measure their hormones.
Yeah.
We want to see what their thyroid status is. We want to see what their sex hormone binding globulin is. We want them to have the basic blood tests. So almost every woman that comes for that first consultation, there's a few things they haven't done. We take a look at what they've done, and we'll augment it. They're all getting blood tests, but we don't test the hormones themselves, because there is no value for that, and they can be deceptive.
Yeah. So you have no, let's call it baseline of each of the hormones before you start treatment. So how do you decide on the dosage of the hormones? When 35-year-old Amanda first scheduled to see me, she'd been suffering for 19 years from severe IBS, diarrhea and fecal incontinence, along with abdominal pain and bloating. Her condition had not only made life uncomfortable for Amanda, but very inconvenient, as she had to walk 2 hours to work every day along a route that had public toilets, and she'd never been on holiday as an adult because of her condition. The only advice that several doctors and specialists had given Amanda was to take Imodium, and when she first saw me, she was taking 5 Imodium a day and wasn't getting any better. To help Amanda, I ran tests to find out what foods were right for her metabolic type, to see which foods she was sensitive to, and to assess her gut microbiome. Tests showed that Amanda had several food sensitivities and a parasite infection. Over the coming weeks, I coached Amanda to eat right of her type and to replace the foods she was sensitive to, and a protocol to deal with her parasite infection, And after 3 months, Amanda was IBS free, and she also reported her skin was much improved and she had lost weight. And she booked a holiday for her and her husband to New York, as they'd never been on a proper honeymoon because of her IBS. And if you're suffering like Amanda was, and you want to get to the root cause of your problem, you can arrange a consultation with me at www.bodycheck.co.uk. And if we're a good fit, I could help you achieve the same kind of results as Amanda. Now, back to the podcast.
Excellent. Most of the women, 84%, have got symptoms of hormone insufficiency. So let's take hot flashes, for example. And they're waking up in the middle of the night with hot flashes, so they got sleep disturbance, big time. So we start them out on a low dose, and we gradually increase that estrogen. And there'll come a time when in almost 100%, what's going to happen is we increase the estrogen, they're going to start getting less hot flashes. And we increase it further, they're going to get less hot flashes. Increase it further, the hot flashes go away. If we increase it too much, we're going to get symptoms of too much estrogen. They'll get breast tenderness. And that's the signal, oh, we went too high, we'll reduce the dose. So the way we're determining dosages with estrogen, progesterone, testosterone is by alleviating symptoms of a hormonal insufficiency while not going so high as to cause symptoms of hormonal excess. These hormones are so powerful that if you do too much, you get symptoms in most, but not every instance. And then once a woman says, wow, my symptoms are good, we do the 24-hour urine hormone test. And here's what we learned by a study that I did personally, is that 25% of the women who say they feel great, they're in an optimal zone on the testing. We know what the optimal zone is. We know what too much is. We know what too little is. 50% of them were not on enough hormones to protect their bones and their vagina. And if they're not getting enough to protect their bones and vagina, their arteries are vulnerable, their brains are vulnerable, their skin is vulnerable. And 25% of them were on dosages a little too high to put themselves at risk for breast glandular cell proliferation. So that testing is imperative. Only 25% of the women who test, because they alleviated symptoms during their dose determination process, only 25% of them are in the optimal perfect zone, not too little and not too much. But once we test them, we never have to retest them. At most, they're going to need a minor dosage tweak. And then we test them annually.
Yeah, that makes sense. So do you, with postmenopausal or menopausal women, do you always start with estrogen?
Oh, well, with postmenopausal women, well, let's define that. With women who've no longer having menstrual periods, 100% of the time, we start with an estrogen called Biest. It has estriol and estradiol in it. 100%. They all need it. There is no exceptions. With women in the perimenopause, 95% of the women were treating with Biest. There's a few of them that don't need the estrogen quite yet, even though they're at less estrogen than they have been their whole adult life. We'll wait a little bit. But 95% of the women in perimenopause, by the time they've shown up in the office, they're estrogen depleted enough that we're starting them on the Biest as well.
So you get them on estrogen. At what point would you may you bring in progesterone or testosterone?
Well, thanks for asking. We start 100% of the women on progesterone. And it used to be 30 years ago that we delayed the treatment with testosterone. There is a certain number of women that in order to compensate for their diminishing estrogen, their ovaries and their adrenals are capable of increasing the testosterone, and the testosterone converts to the estrogen. That's how they're producing their estrogen. And that's the biology of it. So we wait. But what I learned in testing women, that 100%, not 99% of the women, 100% of the women by 3 years are low in testosterone. And then what I discovered over the course of my career, that more and more women were showing up with symptoms of low testosterone. They were getting flab in their triceps area. They were having trouble getting out of a chair because they were losing muscle already. They're getting cough incontinence. They're losing their urine when they cough. Their libido had dropped. Their mood had dropped. Their drive had dropped. And it turns out that, practically speaking, we're starting women off during their first consultation with testosterone and DHEA as well. Because if their initial questionnaire reveals they've got symptoms of testosterone deficiency, we feel like the best medicine is to start them off on that one as well. And of course, we're confirming everything by testing. But yeah, more and more, it's new. It's new, Lay. We didn't used to see this. But now it seems like almost every woman, not every woman, but almost every woman that we're seeing, by the time we're seeing them in perimenopause and early menopause, they're low.
Yeah, it's interesting. I was just about to ask you, do you ever use DHEA? And then you just mentioned that you do.
100%.
Yeah. So you use that pretty much everybody.
Yeah, we combine it with testosterone, and we confirm the levels by test, the 24-hour urine hormone test. They reveal the levels of all of it. Yeah, 100%. I mean, there's no man or woman that has the same amount of DHEA. One of the most prevalent pro-hormones we have in their 50s than we had in our 20s.
Yeah. So just to kind of summarize in terms of working with women, perimenopausal, menopausal, etc., you initially don't test the hormones. You start them on low dosage, and then you gradually build them up until they feel really good, or the symptoms have gone away, and then you test. And then after that, generally, you'd recommend testing once a year.
Oh, yes. Then we follow them annually, men and women. Yeah, and we test them annually, too.
Yeah. Awesome. So I guess the other thing is as well, we haven't got into, is in terms of how do you deliver the hormones? Obviously, there's different ways that you can deliver hormones into the body. Can you explain the different options and which ones you use and perhaps why?
Yes. We ascribe to best practices. And that means for estrogen, we prescribe it 100% in a topical form. It's applied to the skin. It's absorbed beautifully. And like I say, we have patented and invented the organic oils delivery system. Why is that? Because we learned when the birth control pill was developed that a certain number of women on the birth control pill were getting clots in their leg veins, thrombophlebitis. Some of them were actually getting a pulmonary embolus where the clot traveled to the lung. Not a great number, but a certain number of them. And what we learned was that oral estrogen in some vulnerable women caused increased production of inflammatory proteins and coagulation proteins in the liver. And so we don't want that. And so we 100% treat the women with topical estrogen. What we know about testosterone is that in some cases it's unsafe to deliver orally. In the United States, you can't even get an oral testosterone, so we deliver that topically. And then the DHEA and the progesterone, they work fine orally. What we do with our DHEA is we combine it with our testosterone into one single oil. And so we don't necessarily give oral DHEA. Some women, we give progesterone orally. We've been limited as to how much progesterone we can give topically, and women have 100 times more progesterone than they have estrogen. But we've had a breakthrough in our world. We're working with a pharmacist who has brought the price down enough that we can administer much more robust dosages of topical progesterone. So we're in the process of deploying that. But oral progesterone's fine. It doesn't lead to complications.
Yeah. Awesome. So what would your advice be for women if they're in menopause but their symptoms are relatively mild? What would you recommend?
They're the ones I'm most concerned about. And mild symptoms often will be addressed. The ones I'm most concerned about is the 16% of women who have no symptoms. They're looking around and they're saying, what's this big uproar of furor about menopause? My menopause is totally easy. They're the ones I'm most concerned about because the consequences, the deeper consequences of not having hormones, of losing the bones that you brought up right away out of the gate here, losing the muscles, losing the cognitive ability, losing the mood, losing the libido, losing the vagina, getting into adult diapers, they all undergo this. There's very, very rare exceptions of elderly. Physicians who are working with the elderly, we know what's happening to them. Everything I just listed. The women who are 60 and having an easy time, they don't have that perspective of nursing homes, bladder loss, adult diapers. So they're the ones that I'm most concerned about because most of them, if not near 100% of them, they're going to get the osteoporosis. They're going to get the coronary artery issues. They're going to get the adult diapers. They're going to wind up in wheelchairs. So you bring up a really important point there. And the best that we can think of doing is educating. So we got major projects out there to educate. And thank goodness there's folks like yourself who are getting this word out. Without it, how are we going to save the planet, really?
Yeah. Yeah. So what you're saying there is just education is really important.
Yeah, because how are you going to get to the women who don't have symptoms? There's not many of them, something like 16%. But how are you going to get to them?
Yeah. Yeah. I mean, I always say symptoms are a blessing.
Exactly.
Yeah. So if someone comes to you, well, they probably wouldn't even come to you, but let's imagine someone came to you, let's say they're 55 years old, no menopausal symptoms. I guess your approach would need to be different, right? Because if your approach is to treat them until they feel normal and then test them, I'm guessing your approach would be different. Would that be right?
Fantastic question. We know the general ranges. We know, I mean, for example, the bias we use is 30 milligrams per milliliter, 80-20. And we know if a woman goes above 0.3 milliliters, because we administer them through oral syringes, you suck it up and you rub it on your skin, we know that she's in a range that's beyond the ordinary. Now, most of these women are going to get symptoms of overdose. But if we start seeing they're going above a total of 0.3 milliliter per day, we're going to keep our eye on them and really, and because that's how it works. We schedule appointments in an initial series of appointments to keep following up until we do the test. So usually, if a woman, if she goes too high, she may not have hot flashes to alleviate, but if she gradually increases to levels that we're going to recommend, most of these women are going to get breast tenderness, nipple tenderness, breast fullness, irritability. Some of them will even get bleeding again. But as we watch a woman who has no symptoms at all gradually increase, we're going to tell them where to stop. And then we're going to test them. And so the 24-hour urine hormone test just tells us with a great deal of precision if they've gone too much. And we do that with testosterone as well, and we do it with progesterone as well.
Gotcha. So I just want to finish up by talking a little bit more about men.
Yeah.
Something that I see in people that come to me is that they might be in their 40s, maybe early 50s, and their actual testosterone is high, but their sex hormone binding globulin is literally off the chart high. So obviously their free testosterone is negligible. Is that something that you see quite often?
Well, let me ask you a question before I answer it. What got their testosterone high?
I don't. The only thing I can think of is a lot of like physical exercise. Is the only thing I can think of.
You know, honestly, Leigh, I have not run into this.
Oh, interesting.
Except when a man is being treated with testosterone. And one of the reasons, the real clue that you gave was the sex hormone binding globulin got elevated. I smell the man is receiving steroids of some kind.
Interesting.
But the process would be the same. I mean, that would be a medical situation I'd want to investigate. I'd want to look at his pituitary hormones, LH and FSH, because if a young man without any external hormones is getting a high testosterone, you can get robust testosterones with exercise. That's a beautiful thing. But high enough to also simultaneously raise the protective protein that'll bind up that excessive testosterone. Wow, I'd be looking for why is that happening? And I would look at the pituitary gland because pituitary tumors are rare, but they're capable of driving excessive production. I'd look at a testicular tumor. I'd want to rule out actual pathology. More often the case that, and we do see this all the time, the men have been injecting testosterone and they're on too high a dose, and they were on too high a dose enough to raise their DHT and raise their sex hormone binding globulin. And if that sex hormone binding globulin has gotten too high, you know, you'd like to think that if you just gave them the right dosages, it would come down. And the same thing happens with women for different reasons, but it doesn't necessarily come down. In which case, we use a pharmaceutical medication called Danazol. And Danazol works. And Danazol needs to be monitored because it's got some rare side effects that relate to the white blood count. But that's the principal tool to lower a sex hormone binding globulin. When you were talking about, like what kind of testosterone levels are you seeing in the example you gave?
I can't remember the numbers. I couldn't say the numbers, but it's certainly above what would be considered the functional range.
Yeah. It's that the tip off you gave me was with the sex hormone binding globulin. Depending on how high the testosterone is, why did that sex hormone binding globulin raise? It can also raise from administration of other hormones. For example, these are unusual events because they don't often take place, but men who are on thyroid replenishing, if their dosages are too high, that will raise the sex hormone binding globulin as well. Now, women don't like excessive dosages of thyroid. These are the most powerful biochemicals in the body. They usually get jittery. They get a pulse increase. They feel awful, like they had too much 10 cups of coffee in the morning. So I would be happy and honored to investigate any single case that you have with you so we could find the clues of how that sex hormone binding globulin got elevated and whether they're on testosterone that they didn't tell you about or some kind of steroids. And you got to look out because in a world that has integrity, you wouldn't be having this problem. But there are supplements out there that don't reveal that they're putting androgens in there. They don't put it on the label. So there's lack of integrity that can occur. It's pretty rare in the supplement industry. I'd want to know how in the heck did that man get a testosterone so high that it raised his sex hormone binding globulin?
Interesting. Yeah, I think that's the most from the people I'm talking about. I think that's the most likely. They're definitely not, as far as I'm aware, people that have ever used any kind of hormone therapy.
And one thing to consider is there's some time in people like women, we always get a sex hormone binding globulin blood test, always, right out of the gate. Because a lot of the women who went on the birth control pill raises women's sex hormone binding globulin. You got a young woman at the peak of her estrogen production and you're giving her more estrogen, it raises the sex hormone binding globulin. But most women, when you stop the birth control pill, the sex hormone binding globulin goes down. But not all women. Some women, they didn't take the pill for 30 years, and they arrived in menopause with an elevated sex hormone binding globulin. And we want to know about that, and sometimes we've got to deal with that. Well, some men who did bodybuilding and took androgenic steroids 20 years ago, they didn't even remember that they took them, but they did. They're probably prone to the same thing, where if that sex hormone binding globulin raises, but at the same time, they stopped them, we'd expect the sex hormone binding globulin to go down.
Yeah.
But it doesn't always do that. And it's common for it to not come back to normal. So there you are 30 years later dealing with an elevated sex hormone binding globulin. So we want to look at the reasons and we want to look at the numbers. I don't know that I've personally ever seen a man that through exercise, how great it is, rose their testosterone so high that we also simultaneously raise the sex hormone binding globulin. So all of those moving parts, it's not rocket surgery. You just follow the bouncing ball. You go look for what in the heck, how did that happen to this guy?
Yeah. So it could be pituitary, could be testicles, it could be some kind of hormone ingestion, whether done purposely or not.
Precisely.
Gotcha. Awesome. David, I've absolutely loved this conversation with you, but what's next for you?
Well, it's what I'm doing now. I mean, I've got several partners and a team that our mission is to help women and men, millions and millions and millions, get on these hormones and do it right. And so I spend my time training and mentoring physicians and nurse practitioners and really helping people convert to the organic oils when possible, because it's healthier for them. You don't need solvents. You don't need toxic solvents, which is most of the stuff that's in there. And I just go to work every single day with joy. It's a great privilege. It's a great honor, and it's fun to have done this long enough to where it gets even more interesting. And so my team has big ideas, great people. I love them. And so we want to change the world only. That's all we want to do, Lay. And the place of greatest leverage for us is to empower midlife folks at the peak of their skills and their knowledge to feel good. And if they feel good, most of them are going to be beneficial.
Yeah. And if you're in good health, you'd be less of a burden on society and the medical system, as well as being able to contribute as well.
And be able to stay home and be with your family when you're 90, when you're in your 90s. Because people will go into nursing homes, but they don't like it. I have personal experience with family members who went into nursing homes. And I have, as a physician, experience with people who need to do that. And they're willing to do it, but that's not what they want. Yeah. They want to be walking and talking and being with the people they love.
Yeah. Absolutely. And where can people find you online?
BRITE.live, bright.live, and IOBIM.org for the professionals, or iwonderdoctor.com. And of course, there's a free offer. I don't know if you've spoken to Karina. The women can download our PDF version of our book for no charge from your website or your program notes. Karina can assist you to do that.
Yeah, I'll make sure that's in the show notes.
Yeah.
Awesome. Yeah, just one more time, David. Thank you so much. I've really, really enjoyed it. Hormones is definitely a subject I could talk about all day, especially to someone like yourself.
And boy, did I get it. Because we've gone significantly over time, but I went, this man really knows what he's talking about. I'm really enjoying this interview. You asking the most penetrated and pertinent questions, Leigh. Thank you for what you know and what you're doing out there.
Yeah, thank you. And thank you again for your time.
You're welcome.
So that's all from David and me for this week. But don't forget, you can join me same time, same place next week on the Radical Health Rebel podcast. Thanks for tuning in. Remember to give the show a rating and a review, and I'll see you next time.